Well, today we are joined by the System-Wide Director of Critical Care Medicine for Lifespan, Dr. Mitchell Levy. Doctor, thank you so much for joining us today.
My pleasure, Kim.
I wanted to talk to you as we approach the anniversary of the first identified case of COVID in Rhode Island about the changes in treatment that we've seen for the virus. Can you take me back, doctor, to when this first emerged? Were doctors, how did doctors approach this when the virus first arrived here in Rhode Island? Was there any sense of how to treat this?
Yeah, it's obviously a great question, Kim. And looking back on it, the first case certainly here in Rhode Island was in the late February at the Merriam Hospital. It's remarkable when you think about the fact that the disease itself is a little bit more than a year old. So that's just so astonishing when you also consider that there have been so many millions of cases worldwide, and I think at least 25 million in the United States alone. So, and so many deaths as well. And yet in the beginning phases, I would honestly say is the first 6 months until the release of discovery results, which was with dexamethasone in July. So that's 7 or 8 months. In the beginning, we were just learning about this terrible illness and really were feeling our way as if it was the blind leading the blind, to be honest. We knew that this is a devastating disease. We knew that it causes a lot of we know that it causes a lot of clotting in the lungs and the blood in general. And we know that it causes lung injury. So in the beginning, we were using mainly supportive care. As we know, the mortality rate overall from COVID-19 is quite low. It's less than 5%, but about 20% will develop a need for hospitalization. And of that, about 25% of the people who are hospitalized wind up needing critical care. So they're not small numbers. But overall, the message has always been, this is not a fatal disease. But when it occurs, especially in patients with diabetes, high blood pressure, and the elderly, the effects can be devastating. In July was when the first results were available that showed that a simple steroid, dexamethasone, that has in fact been studied in lung injury for years, almost 40 years, was found to be not just effective in improving outcomes, but improving survival as well. And that's after many drugs were found to have failed, most notably hydroxychloroquine and azithromycin. And so that was a big step that we learned that simple steroids once a day for 10 days made a difference in survival.
Certainly, I want to talk about the steroids and the treatments, the monoclonal antibodies that we've been hearing about. I do just want to look back a little bit further to sort of how this all began. Initially, doctors thought this is a respiratory illness. Is that still how you would classify coronavirus today?
Yeah, that's a great question. And that's exactly the way we see it. In fact, many patients are admitted to the hospital before they develop severe lung disease with simple COVID pneumonia. And there is no question that the entry point of the virus is in the back of the throat. And then later on, after about 7 or 10 days, it goes into the lower respiratory tract. And so it's definitely first and foremost a respiratory illness. And then after about 10 days, if things progress, it begins to affect through the same receptors, it begins to affect the rest of the body.
And so initially, I know some of the more severe cases, those patients were ending up on respirators. Is that something that you're seeing as commonly now, or folks ending up on respirators, intubated as frequently?
I would say a little less so. We're using a little more what's called high flow nasal cannula. So we're getting better and more comfortable with keeping people on the wards and in the ICU with the use of devices that create a lot of airflow into the lungs without the need for putting a plastic tube in someone's lungs and putting them on a breathing machine. And so we're able to keep people off of mechanical breathing machines, mechanical ventilators, for longer periods of time.
I want to get back to the treatments you were talking about, steroids, monoclonal antibodies. Can you sort of walk us through what is available to patients who develop a severe form of COVID right now?
Yes, of course. So First came the dexamethasone, the steroids, as I said, and then probably the next big introduction was the use of a series of monoclonal antibodies, not for people who were in the hospital, but interestingly enough, for patients before they became hospitalized. So outpatients for infusion of these monoclonal antibodies. These are monoclonal antibodies that fight the virus that's in the blood in patients before they get sick, and have been shown, the combination of these antibodies, to reduce the likelihood of progression to needing hospitalization. So those monoclonal antibodies are produced by several companies. In fact, those monoclonal antibodies are the same antibodies that former President Trump received when he went into the hospital, and they're now much more widely available. They're about to receive an emergency use authorization from the FDA, the Federal Drug Administration, for use in outpatients prior to hospitalization. So that's a very, very important advance.
Can you talk to us about what doesn't work? You mentioned hydroxychloroquine earlier. Have there been any other drugs that you've seen that have been tested and failed to make a difference in coronavirus patients?
Yeah, that's a great question. And part of the challenge is many national governments, not just ours in the United States, but many national governments, because of the urgent need for new interventions, have poured a lot of money into research. And unfortunately, there have been a number of trials that have not been done all that well, or are very, very small. And then there's a lot of misinformation available on the internet. And so therefore, we hear the public go, oh, what about ivermectin? And this also is involved with hydroxychloroquine. So people share stories that they've heard about, and we have people coming to clinics asking for various interventions that haven't really been proven. And ivermectin is also one of them, as is hydroxychloroquine. So ivermectin was subjected to a few clinical trials, mainly small clinical trials. I'm on the National Institutes of Health, the NIH guidelines panel for COVID-19 that was appointed by Dr. Fauci. And we recently reviewed the ivermectin data and felt that there were insufficient evidence to really recommend for or against the use of ivermectin. We just didn't feel that the data are strong enough to recommend it. But we received a lot of criticism because, as I just said, people are on the internet all the time and they're hearing, oh, this works. It's been tested in Peru, in other places. And there's so much information, misinformation. And there's also so much concern and panic when your loved one or you get COVID-19, especially when it gets worse. We would want anything for it.
In terms of the treatments that do work, from your professional perspective, even just, less than a year into this, is it kind of remarkable to see how far we've come in such a short amount of time?
Well, absolutely. There's no question. This disease is a year old. We have multiple. Remember, I think it's just as important to have a negative trial as it is to have a positive trial. So we have a number of negative trials. There's so much information now that simply says that hydroxychloroquine, with or without azithromycin, is not only not beneficial, but might be harmful. So that's a very important advance. The next is the ivermectin story. So up to now, we've had a number of trials that have failed to demonstrate the benefit. And now with the monoclonal antibodies, there are a number of trials, quite a number of trials that show that for outpatients, this is an important advance. So I think the important point here to emphasize is we now can treat patients before they get very sick and after they get very sick. There's also a new agent called tocilizumab, which is an antibody against interleukin-6, IL-6, which is an inflammatory marker that's increased in COVID-19. Now, the data are still quite new, and it's not clear what the overall results are. And so we in the NIH panel are not yet recommending them. But again, just look at all of these agents. and all of these trials that have been done. And even more importantly, and we haven't said anything about this yet, there's a vaccine. There's a vaccine, depending on the vaccine, the Pfizer and Moderna vaccine are 95% effective, and the others are in the 70% range. So put that in the context of the simple flu vaccine that so many of us get is only 55% effective. So to have a vaccine, the disease is less than a year old, to have a vaccine that's 95% effective in less than a year is just astonishing. And it's a good mark of when we put our minds together as scientists and the will of the population and governments to fund this research, how quickly it can be done.
Do these advances give you hope that we can apply this type of research, this type of speed, this type of accuracy, as you're mentioning with the efficacy of the vaccine, to other treatments for other diseases?
Yeah, I'm smiling because a lot of my work is in sepsis. And so COVID-19, when you develop organ dysfunction, whether it's respiratory failure or renal failure, or even some of the effects it has on the brain or shock, these are all commonly associated with COVID-19. That is sepsis. It's just a viral sepsis. And that's no different than the things we see with bacteria, or that we see with other viruses, or with the flu for that matter. And so it does give me hope that if we take the lessons learned from our response to COVID-19, they may well apply to other diseases that we've been very frustrated by in the past.
Doctor, what am I neglecting to ask about, or what else would you like to let people know?
Well, just the one thing I always end with is we still have to wear a mask. It's still important to socially distance. We are the only country in the world that politicized mask wearing and social distancing, and that's just heartbreaking for those of us who are scientists. So we still don't know whether the vaccine prevents us from carrying the virus. We think that it might be, and my understanding is there are some data now that are going to be published that will make us feel all more relieved of those of us who've been vaccinated of not being able to even carry the virus inadvertently. But until that's convincingly out there, it's still important for us to mask and socially distance. And that's all I would say. The other thing is the data from the vaccine, and I know people have some reluctance to take the vaccine. The data from the vaccine are really demonstrating the safety of it and the effect of it, the beneficial effect of it. So I would also say, remember to wear masks, and please consider taking the vaccine.
Dr. Mitchell Levy, thank you so much for your time.
My pleasure. Thank you, Kim.